Hello, everyone. I'm going to wait just a second until all of the audios kick in. Hello, members. My name is Nancy Murr, and I am with OLLI at Berkeley, and we are delighted to welcome you back to another COVID Q&A with Dr. Deborah Gold. We were just trying to determine the exact number of Q&As Debbie has given to us over the course of the past 2.5 years. And it's anywhere from close to 10 to, 112. It's just an inordinate number of Q&As in which she has given us tremendous information and grounding in where we are with the pandemic. So Deborah Gold, for those of you who are new to this, is a retired infectious disease subspecialist and a hospital epidemiologist. During the height of the pandemic, and maybe we're still sort of in a height of a pandemic, Debbie gave more than 80 presentations to frontline providers across the country through the MAVEN project. And if you're not familiar with the MAVEN project, I recommend that after this presentation, you Google it. The MAVEN project serves underserved populations, including the poor, the elderly, and the uninsured across the country. So Debbie, we're just going to get right into it.
Okay.
Once again, this is a very brisk 60 minutes. We're going to start with questions that were submitted in advance by members. And then if there's still time, we'll go through questions popped into the chat. Okay. So members maybe listen, and if you feel that a question you would have asked has just been asked, no need to submit it into the chat, but otherwise go ahead and do it.
I should add, I would just like to add at the beginning that I'm
Yes.
very conversant on monkeypox also. So in case anybody has a question about monkeypox, I'm really up on that too. Okay, go ahead.
Fantastic. Okay, great. So Debbie, the first question, when I browsed through the several dozen questions that were submitted in advance, they fell into some not surprising buckets, including boosters, travel, outdoor gatherings, and so forth. So why don't we start with boosters? According to the people who submitted questions in advance, most everyone has received 1 or 2 boosters. What should happen now? The efficacy seems to wane over a short period of time. They hold off, get a third. What do you recommend?
I think it's difficult at this point to specifically say when the next booster should be taken. I would suspect that we won't have the Moderna product, the hybrid booster, which will probably come first, much before the end of September or early October, even though I think the company is saying sometime in September, depending on when you had your last booster. Your last booster may determine when you take the next one. And by the way, this overall, like a booster every few months, this is not going to be a sustainable model if in the long term, but for right now, while we are dealing with highly transmissible variants, there's really no choice about it. We're going to have to be boosting again and again. The protection against infection after you get a booster is very short. For the second booster or the 4th injection, the protection peaked at 3 weeks after the second booster. And at that point, at 3 weeks, it was 65% protective against infection. Now that's different from protection against severe disease, hospitalization, and death, which are pretty high, but it is the goal of vaccination to prevent severe disease, hospitalization, and death, and not infection. That is no longer a goal because the vaccine does not really protect against infection in a very robust way. And that's important for people who don't want to get infected, who are immunocompromised, or like me, who just don't want to get infected. And I'm happy to expound on that. But at this point, I think it's unclear when those hybrid vaccines are actually going to be available. There should be one from Moderna and one from Pfizer. Novavax is also seeking emergency use authorization to be used as a booster. And so that may be present a third option for people who want to take a dose of vaccine that's made in a completely different way from the mRNA vaccines. So I think we kind of have to wait and see what transmission rates are like in the community, what levels are in the sewage surveillance, and sort of try and get all those data points in order to figure out the right time to take a booster. Also, if you're planning to travel, and I know we're going to get into travel or attend a very large event, it may make sense to time your next booster to be 3 weeks before whenever that is. We had a wedding in our family, and I took my second booster exactly 3 weeks before the wedding, which was outdoors, 100% outdoors.
Okay. So I am going to then follow up when you invited us to ask you why don't you want to get infected?
Oh, okay. So I could spend the whole time about why I don't want to get infected, but I think I've mentioned a number of times in the past that when I was a fellow doing my subspecialty training, one of my side projects was chronic fatigue syndrome, which used to be thought to be related to Epstein-Barr virus and all kinds of things. And so I dealt with a large population of patients in our viral disease clinic at the University of Washington who had chronic fatigue syndrome. And so I'm very familiar with those kinds of patients and what they suffer. I actually at that time thought that they had somatization disorder, that this was a psychiatric thing. But when long COVID reared its head in the context of this pandemic, I realized, oh my God, those people have chronic fatigue syndrome. I know those symptoms. I know that clinical scenario, and I don't want to get near that with a 10-foot pole. I do not want that. I am retired now. I want to be able to enjoy my retirement and not be impaired in any way. And those individuals are severely impaired, some of them even in their activities of daily living, and I want none of that. So now I think chronic fatigue syndrome had a viral trigger. It didn't have Epstein-Barr virus as its trigger, but there are probably many viral triggers, of which SARS-CoV-2 is one. And so I don't want to get long COVID. The other reason I don't want to get COVID is because there are some very compelling, huge studies that have been done in the Veterans Administration system, and they have a database with millions and millions of veterans, and they can do very robust, powerful studies in that system because most veterans won't get all of their care in that system. And so there were 2 studies that were published by investigators at St. Louis University, I think it's St. Louis University. We had a couple of residents who had gone to medical school there. I'd never heard of that.
Washington University in St. Louis?
No, not
okay.
It's in St. Louis, but it's not WashU St. Louis. It's another medical center there, and it's they have a medical school there. So these studies, the first study showed an increased risk of cardiovascular events within 12 months of having a COVID infection. And by cardiovascular events, I mean everything. I mean stroke, transient ischemic attack, acute coronary syndrome, congestive heart failure, cardiac arrhythmias, pulmonary embolus, deep venous thrombosis, every kind of cardiovascular event that you can imagine. The risk of that was increased in veterans who had had COVID within the last 12 months compared with veterans who had not had COVID. So I found those data to be very compelling. And now a similar study was done also using the VA database, showing not only increased risk in cardiovascular events, but also increased risk for gastrointestinal events and pulmonary events and renal events. And basically, bad things happen within 12 months of having COVID. And it's not the only infection that confers increased risk like that long term, but it's certainly been shown in what I think is a very robust way that there is risk beyond just having an acute event or getting long COVID. You can get bad things can happen because of this probably because of some ongoing inflammatory process that's happening, and it can affect almost any organ system. Oh, central nervous system, I forgot that.
Oh, okay.
Parkinson's disease, dementia, all of the risk for all of these things is increasing. To me, that is just super scary. I do not want COVID infection. And these are people who were not hospitalized with COVID. These are people who had mild infection or who had infection where they did not require hospitalization. So this is not the subset of individuals who were really sick in the ICU on a ventilator for, 14 weeks. These are people who had just mild disease, not requiring hospitalization.
Is there any connection to age within that group?
So I don't recall if there was age stratification. There might have been, and I didn't read these studies as carefully as I would have if I had been presenting them. So they must have done age stratification, but I don't remember what those data were if they did.
Well, this dovetails very neatly into a couple of questions posed in advance, including correlation with strokes, heart attacks, and so forth. One question was, my husband had COVID, was asymptomatic at the age of 78, went on Paxlovid, had stroke-like symptoms on the last day of the meds, diagnosed with AFib in the ER, returned to the ER having a stroke. Doctors felt COVID played a role. Is there more to expand on than what you've already said about
No,
that?
I think, that kind of thing could happen just because that happens. I mean, we see that kind of thing all the time, but with the proximity to COVID and knowing that there can be cardiovascular events and it doesn't have to be concurrent with the COVID, it's unclear whether treatment modifies this risk. That's unknown. So treatment with monoclonal antibodies or treatment with Paxlovid or which is really the only antiviral that we're using, we don't know if it modifies the long-term risk for adverse cardiovascular events. But I would say, probably related. The COVID could be associated with new atrial fibrillation, which can occur in the setting of acute illness, and then clot forms in the left atrium, and then you get a stroke as a consequence of the atrial fibrillation. So that fits together nicely for me.
Yep. So Debbie, several members have outdoor events planned in August and September. Any recommendations? I mean, when the CDC came out last week and made revised the guidelines, sort of a sharp move away from measures such as social distancing and quarantining, that kind of thing. So first, talk about outdoor gatherings. Is it okay for people to not wear masks, even when not eating and drinking, just being sociable and not wearing a mask?
So as I've said before, it sort of depends on your risk tolerance. So at this outdoor wedding that I went to, which was during Omicron, which was during BA.5, I did not wear a mask, even when I was not eating and drinking. I think that, did we have to test? We had to test before the wedding. So everybody had to test that day. So I thought that the risk was low, but not zero. And so I did not mask, and my 96 and 92-year-old parents did not mask, except for a very brief period of time. And I thought that that was pretty safe. At the dinner the night before the wedding, which was also outdoors, there was one individual who then the morning of the wedding tested positive. And so there were 6 members in that family of one person who tested positive who didn't attend the wedding. But there weren't any other cases of COVID, but certainly, you know, things like that pop up. And so it's not zero risk, but it's pretty low risk being outside. And I'm scheduled to go to another wedding in about 2 weeks. And it's actually an indoor wedding. And I'm going to mask indoors, but probably not outdoors.
What would you say to a member who is hosting an outdoor gathering and there is an unvaccinated person planning to come who says vaccination doesn't decrease transmission, therefore just being tested and wearing a mask should be sufficient? Would you?
Is that if the individual who is unvaccinated, which just totally, like, it's so hard for me to wrap my head around that. If that person tests on 3 consecutive days and is negative on 3 consecutive days, I would consider that person probably uninfected, not a guarantee. And I guess if that person is allowed to attend, I would just stay away from them. I think the safest thing would be if that person would also wear a mask. The CDC has recently said that for asymptomatic individuals in the time now of Omicron subvariants, that it's necessary to have 3 sequential negative tests in order to have some assurance that you're really not infected. And by the way, if during that 48 to 72 hour period, that individual is doing higher risk activities, then there's no assurance. That person really has to follow some, reasonable measures to prevent infection during that period of testing. Individuals who are not vaccinated generally are not going to have that kind of cooperation, I don't think. So I would, if I knew who that person was, I would really be staying away from that person, even outdoors.
Okay. So you mentioned the CDC and the guidelines. Can you just review kind of the new guidelines and what the recommendations are?
Yeah, so the CDC says that they are moving away from mitigation measures and want to focus on protecting more vulnerable individuals. And that to me is like, what? It increases risk for vulnerable individuals when the CDC says we don't need to do social distancing anymore, that masking, mandates can be relaxed. When people are exposed, they don't need to quarantine anymore. And I think the emphasis is on early treatment. So identifying individuals who are infected and then getting them on Paxlovid or bebtelovimab or early on to try to prevent severe disease, hospitalization, and death.
Well, that Paxlovid relapse seems to be fairly, it's not uncommon. I'll put it that way.
It's not uncommon. How, in fact, I have a friend who was just traveling in Europe on a Rick Steves 21-day tour. And of course, it was very hot in Europe. I mean, it is very hot there now. And they couldn't eat outside. They just were eating inside. And of course, got a COVID sort of somewhere between the last day and the airport and whatever, came back with COVID. And so there were two friends, and one got COVID, the other one didn't, and then the one with COVID gave it to the other one. And the first one actually had a relapse, had a negative test and then positive again. But I would like to point out, and I think this is really important, that in the phase 3 study of Paxlovid for treatment of COVID, that rebound was also seen in the placebo group. And so rebound is a phenomenon of SARS-CoV-2 infection and is not peculiar to individuals who are taking Paxlovid. And there are other viral infections which can exhibit this kind of rebound phenomenon also. So I don't think it's special, but it does happen. And it's when people are taking treatment and want to, know when they turn negative, all of that goes on in individuals who are being treated. But if we had a group of individuals who weren't treated with Paxlovid, we would also see that pattern in some, low percentage of people with infection.
Okay, that's interesting. Before we leave the gathering series of questions, one member asked, there are going to be talks at the gathering. Is it still necessary, or was it really ever truly necessary to wipe down the microphone in between questions?
Oh, that's a good question. I think people who are speaking in a microphone are not, you don't have to yell or, project because you have a microphone there. So, but I think you're pretty close to the microphone, and droplets could get on the microphone. And then the next person could come and they could adjust the microphone and then rub their eye and then, or their nose. And then they, I think I'd be wiping down the microphone. Yeah, I don't, that's
okay.
That's a reasonable thing to do.
All right. Good. So next series of questions involves travel. As you know, OLLI members like to travel, and we've all been sort of cooped up for 2.5 years now, and we're ready to hit the road. So generally, what is your opinion about plane travel at the moment, and how do you handle, or how would you recommend handling plane travel?
Okay, so I'm very risk averse, and I'm not traveling by plane. I'm camping still, just camping. But I think that there are some things that can be done to try to reduce your risk. Be aware that depending on what part of the country you're in, maybe half the people, like around here, half the people will still be masking. But if you go like to the Midwest or the South, or, no one is you're going to be the only one masking on the plane. So for domestic travel, there's never been a requirement to show evidence of a negative test to get on a domestic flight. So it's always been possible that you could be sitting for 6 hours next to somebody with COVID who either doesn't care that they have COVID and they're going to get on the plane anyway because they don't want to lose their ticket, and they're not going to mask. So you could be in a situation like that. So it makes sense to wear a good fitting N95 or KN95 mask for the entire flight, and also the period of time in the airport, because there's no social distancing anymore, and many or most people will not be masked. And people will go to work and will get on a plane with COVID, and they do not care. So if I were an immunocompromised person, I would not put myself in this kind of situation. Because you're not, when I was working, I was fit tested to wear an N95 mask. So I know the mask that I was fit tested to wear that will protect me against something like that. But you all out there, you're not fit tested. So you're just like trying to do the best you can with a KN95 or an N95, and it may not be the best fit for you. And I've seen people wearing those masks that are totally wrong, including my sister and my brother-in-law. Like, I'm not even going to say anything anymore, but so you could be sitting next to somebody or you could get into a cab or an Uber with somebody that has to work who also has COVID and may or may not be wearing a mask. So there's risk. And if you want to assume those risks, the best way that you can try to protect yourself is to wear a mask. And you may be the only one, and people may be looking at you like, what are you doing? And thinking, oh, you must be from California, you're wearing a mask.
Having been in an airport where I think maybe 5% of us waiting were wearing masks, you are not that you particularly care, but there is a point of thinking, what is the point? I mean, I am surrounded by all these non-mask people. I am cheating a little bit because Marilee just posed a question in the chat related to what you just said. Then we're going to go back to cruises. What is fit tested? You said your sister and brother-in-law
well, my sister
ill-fitting masks.
Yeah, so my sister has never been fit tested. People like I had to see patients with tuberculosis, with disseminated varicella, with all kinds of things that are airborne infections. So I needed to be fit tested so that the fit was correct and I could repeat that fit every time. And it's a process you have to go through. It takes half an hour. They put a hood over your head. There's a hole in the hood. They spray in this stuff that tastes really bitter, and it's super potent. So if your mask is not fitting well, you taste that stuff right through the mask. And so they put you through all these kinds of maneuvers in order to make sure that you never taste that stuff that they keep spraying into the hood. That's fit testing. It's kind of crude, but I think it actually does have some meaning clinically, that somebody who can never taste that stuff is really protected.
Okay, wow. So back to cruises, that was another question, right? So, airplanes, you're on, you're off. At some point, cruises, you're there. So what are your thoughts about cruising right now?
So cruising, I have been on a couple of cruises, which I really liked because I didn't have to make dinner. That was really awesome, not to have to make the meals. So you're in the breakfast line, there's no social I can't imagine people are distancing at all. And most people are not going to be wearing a mask on a cruise. There are outdoor places where you can park yourself and at least reduce your risk because you're outdoors. But if you want to go to a show or you want to go to a whatever, those indoor kind of venues are probably, not as safe. And again, people are not going to be masked. If you're sitting at a table with other people who are talking really loud, drinking a lot of alcohol, which fuels the talking really loud, that increases risk of transmission. And of course, you can't eat and be masked. So I think anytime you're eating, there's going to be risk for transmission. And we know that transmission occurs on cruise ships, even when people must be vaccinated, must have a negative test 72 hours before getting on the ship, and then have another test the day of embarking, going onto the ship. There's still transmission that can occur, in passengers and crew. So I think that I think it's not such a safe thing to do. That being said, I do every Friday, I Zoom with infectious disease colleagues. We talk about COVID, but we also talk about other things. And two of them are going on a cruise to Japan in April of 2023. So good luck to them, I say.
You'll have a lot to talk about in May of 2023.
Yeah. It's a really long cruise though.
Okay. So, and then the last of our transit questions, closer to home, bus travel, BART travel, you're in and off these kind of congested spaces. Any thoughts on that? Just wear a mask or not?
I thought that masking was required on BART now. I might be wrong about that. I'm sure people out there probably know, but I would wear a mask on Muni. I would wear a mask on BART, on AC Transit, anytime I would be, I'm and I haven't been riding. In fact, I was teaching an OLLI course in the January to March of 2020. And the last day of the class, I took Bart home from Berkeley, and I said, "This is my last Bart ride," and that was my last Bart ride, March of 2020. So I have not been on public transportation.
And for those,
and if you are, then
yeah.
you should wear a mask. My son takes public transportation and he wears a mask.
Okay, all right. Let's see. Here is a question, and I know this is from a scientist who's an OLLI member. Is it known yet which animals harbor SARS-2 that will act as viral reservoirs
There
for
are
seasonal outbreaks?
Yeah, there are probably lots of animals that can harbor the virus. Certainly cats and dogs and all kinds of feline, big cats, bobcats, all of that family can harbor it. Foxes can harbor it. There was a paper that was published a few months ago that listed all of the animals that can harbor it, where there was concern for establishing animal reservoir. Rodents, I don't believe were on that list, but fox was on that, wolf was on it. If you want to see that paper, I could try to find it, and you could send send a message to me, and at Debbie Gold 2 Steen at gmail.com. Debbie Gold, all one word, and then the number 2, and then Steen, STEIN at gmail.com. I could try and find that paper for you, but there's certainly concern about establishing animal reservoirs where we could see spillover into where certainly viral replication can occur in these animals, and ongoing mutation, and then spill over into humans. And that's certainly certainly possible.
So the follow-up question is this not how this virus will become endemic?
I think that we don't even need an animal reservoir for it to become endemic. I think that we just have to have non-immune people and people who have some degree of immunity where transmission is going to be ongoing in the population. I don't think we need an animal reservoir. Okay. It's just going to happen on its own, because infection with the virus does not confer protection against infection again. And we knew that from coronaviruses before SARS-CoV-2, that you could get a cold, and then you could get another cold, and you could get another cold. And obviously there are a lot of viruses that cause colds, but coronaviruses, of which there are 4 different human coronaviruses, cause the common cold. And certainly getting a coronavirus upper respiratory infection does not protect you from getting another one in the next season.
So what would eventually cause the fizzling out of SARS-2?
I think it's always going to be with us, just like influenza is with us, just like lots of infections are with us. I think people will experience mild disease. They'll still transmit it to other, household members, coworkers, etc. We're probably going to have 1 booster shot a year. Hopefully there will be a universal vaccine that will be developed that will protect us against all coronavirus variants, so that we don't have to keep getting boosted every time a new variant comes on the scene. But I think that's just how it's going to be. And now when we see people like people coming into the clinic who may be tested for influenza with a rapid test, they're going to be tested for influenza and also for COVID with a rapid test, because the treatments there are treatments available for both, and they're different. And early treatment impacts the clinical course of both of those infections. So I think that it's going to be eventually like influenza, and we're going to see people hospitalized every year, maybe throughout the year, with COVID in the hospital on a ventilator and die. That's just going to be a thing. That's how I see it happening.
One of the final questions submitted in advance, and then we'll move over to the chat again, circles back to Paxlovid. Just, can you give us a sort of breakdown of, but not too technical, breakdown of how it works? Why is it only given to older adults at this point? Is it the vulnerability of older adults that's driving that decision? And are there side effects that you're aware of?
Yeah, so Paxlovid it's an antiviral. It just prevents viral replication. It's a combination of two antivirals. Actually, one of them, ritonavir, is a very common antiviral that we use with a lot of HIV drugs, and it's just acting as a pharmacokinetic agent to increase the blood level of the other component. And it is given to individuals who are over 60, because the Israeli data suggests that it doesn't have efficacy in individuals who are under 60. And I'm maybe in Israel, they use 60 as the cutoff. They may use 65 here as the cutoff. I'm not really sure, because I don't prescribe it myself, obviously. And it is also given to individuals who are under the age of 60 who have risk for progression to severe disease. And so one of my Friday friends with whom I have this Zoom, her daughter, who is 27, got it because she has a risk for developing severe disease. I think there were 3 parts to your question, and I maybe only answered 2 of them. But
side effects.
Oh, side effects. So I think the most common side effect that I have heard of from individuals who I personally know who have taken Paxlovid is a bad taste in the mouth. And that was so bad that my niece, who took it, actually it was making her nauseated. The taste was so bad, and she couldn't actually take the Paxlovid, and she didn't really need it anyway. She thinks she has autoimmune disease, but I don't really think she does. And so thought that she might be at risk, and so she got it. In fact, I told her to get it, and then she ended up not taking it. So I think the main adverse effect is a bad taste, but just like any drug, you could have, nausea, vomiting, diarrhea. Those are pretty common side effects for most antivirals and antibiotics, for that matter.
So going into the chat, there are some booster questions again. Your 3-week window was elucidating for sure. So people who had their second booster in June, when would you recommend they get a new one that has better coverage?
Yeah, so I got my second booster in June. And I, so I look at the New York Times COVID tracker every morning. It's actually the first thing that I look at before I even look at the New York Times. And so I look at what the transmission rate is, what the hospitalization rate, what the death rate is in San Francisco. And, things seem to be, well, except the death rate, I think the data are kind of messed up, but it looks like the cases are going down a lot. I think that I'm going to reassess at the time that the vaccine becomes available. And the booster dose becomes available, and just kind of see where things are in terms of transmission, because here it doesn't get very cold, so we can stay outside for a long time. And I'm having people over for dinner, we just eat on the deck, and that's okay. I feel like it's low risk. So I don't feel really compelled. If I had a trip planned, I would try and take my next booster 3 weeks before going on the trip, if my last booster had been in June.
Jody asks, she was intrigued by the 3 negative tests correlating with non-infectivity. Right? Does that apply to people who are symptomatic?
No, it's people who are asymptomatic.
Okay.
So people who are symptomatic is a different thing. If you're symptomatic, then 2 tests 24 hours apart is what is recommended. In a situation where there is high transmission in the community, and I was going to have like somebody staying in my house, or I was going to be in close proximity to somebody who had typical symptoms of COVID, which is like having a cold basically, and they had 2 negative tests, I would feel better if they also had a PCR or a nucleic acid amplification test like Google employees get. I would feel better with sort of an extra layer of knowing that they really do have just a cold and it isn't COVID. And there are lots of tests, so that doing 3 tests, that's a thing. There are lots of tests that have a sensitivity of about 70%, just in general, like checking a stool for Giardia. The sensitivity of that used to be, when I was in training, was about 70%. So we would get 1 test a day for 3 days to make sure that we were ruling out Giardia. The same thing with Legionnaire's disease. If we were measuring sputum for Legionella, the sensitivity is pretty low. So we might get 3 tests 24 hours apart to convince ourselves that there really was, that nothing was getting by us. And this is kind of the same idea, that the sensitivity of the home rapid antigen tests is reduced for Omicron and Omicron subvariants. And so you don't want to miss something. So you do, for an asymptomatic person, you would maybe do 3 tests instead of 2.
Okay, so speaking of tests, I just noticed that a couple of the ones I have expired.
Yeah, so the FDA has extended the shelf life of these tests 3 to 6 months. It depends on the company, depends on the manufacturer and what kind of data they submitted to the FDA to indicate how long their test is actually good for. So this is, those tests were not developed very long ago. And so they had to put some arbitrary expiration date, but they're probably good for much longer than that. And as the companies, the manufacturers are accumulating data, the FDA is extending those. So I have a gazillion tests in my closet downstairs, and they are expiring October 14th and November 14th. But if you go on the FDA website, if you just Google COVID home antigen test expiration, you'll get a hit from the Food and Drug Administration, and it will list by manufacturer which tests they have determined or have an extended shelf life, and then it'll say if it's 3 months or 6 months.
Okay, that's good to know. I'll go check it out. Someone is planning to see Harry Potter and the Cursed Child in 2 weeks. She is assuming that a mask should be worn throughout the performance. Is that what you would recommend?
I would, okay. But you know what? People won't be. In San Francisco, even there will be a lot of people who won't be, and people who got those tickets a long time ago and then got COVID, and they're like, I am using these tickets. What am I going to give these tickets away? I'm going. And so, you could be sitting next to somebody who, or tourists. That's the other thing. Tourists who they come to San Francisco, they go everywhere, they do everything, they get COVID. It's just like I'm not going home. So they, whatever. And you could be sitting next to one of those up in the, in the balcony, and they're not wearing a mask because they're from God knows where. So you should wear a mask.
And what about children? I mean, you
And
could also
children,
be sitting, you know,
children. So children, can be vaccinated now. The vaccination rate for kids is super low if for the under fives. And so you could be sitting next to a kid who's, maybe has a cold, has COVID, is not vaccinated. And so I would wear a mask through the whole performance.
okay, all right. Joe would like to know because you mentioned a universal vaccine. Will a universal vaccine prevent infection, or will it protect against severe disease?
Well, so far there is no universal vaccine that has advanced very far. So the answer to that is we don't know. I think the ultimate goal is going to be to prevent severe disease, but if it prevented infection, that would be absolutely amazing and wonderful. There are vaccines that do prevent infection, and measles is the prime example of that. Not only does it prevent severe disease and death, but it also prevents infection or reinfection. So it is possible, but I think we're probably a few years away from seeing a universal vaccine.
So does that mean we have a few years ahead of us of boosters coming out, like every
Yes. Yeah.
4 months?
Yeah. No, I don't think it's
Or
going to
6
be every
months?
3 or 4 months. I think it's going to be once a year,
Okay.
because this isn't sustainable.
Yeah.
And now the government has been paying for vaccines, for Paxlovid, for bebtelovimab, for all the treatments, and they are moving towards having insurance companies start to pay for those. So it's not going to be so easy to get a booster, things are going to change a lot in the fall as that transition happens. And so I think this just isn't going to be a sustainable model where big healthcare facilities have these, drive-through vaccine stations, drive-through testing stations. Those are all going to go away because those are not going to be cost effective anymore. And there's going to be a shift in how we access these vaccines. I think it's going to be a once a year thing.
Wow. And so
next year. So next
Yeah.
year, I mean, so yeah.
Sarah wants some clarification. So when you say to test, 2 or 3 days back to back, is that 24 hours apart? I assume that's what you mean by.
Yeah, I think they said, I think I read that it was maybe 3 tests in 48 hours. So, but you could do 1, 2, 3 tests in 48 hours, 1 at the very beginning, 1 at the 24-hour mark, and 1 at the 48-hour mark. Yeah.
So for the youngins out there, meaning the 37-year-old daughter, according to Mimi, the kids, a 37-year-old has had a booster in the spring going to Europe. Should she get a current booster before she goes? Wait till the new boosters come out. I mean, can you get a second booster when you're just a baby?
No,
37? I
don't think so, unless you just went in and said, I've never had a COVID shot before, and you get a new card and you start over. I don't think there's a way. I think that I would try to carry some Paxlovid and carry testing with me if I had to go to Europe. That's what I would do. I would carry Paxlovid. And I don't know how easy that is there are ways that you can get it. And I would carry test kits with me too, so that if I got symptoms, I could start treatment promptly.
Okay.
And I would bring a lot of test kits with me.
Bring a lot of tests. Marilee was just mentioned she took eye health tests that she got through the post office with her to Australia, when to use them prior to returning home. And this must have been when they were, requiring tests and they weren't acceptable in the US. So, but I think those restrictions have gone
There's
away.
no testing
So you're just like
requirements anymore,
hop on a
not only
plane.
for domestic, but not for international travel either. So, you know, my best friend's daughter went to a wedding in Mallorca
Ah,
and got COVID on the last day. Did she get on the plane to go home? Yes, she did. So she was wearing an N95 mask, but not a fit tested N95 mask. So there you go. It just, you know, happens. People
okay.
do it.
Yep. What about, can you go back to talking a little bit about kids under 5 being vaccinated? So 4 kids, everyone's vaccinated, but they're hesitant to get the kids under 5 vaxxed because they have had mild disease. And I'm not sure if that means they had COVID, mild COVID. I mean, I don't know, but
Yeah.
talk about vaccinations for the under 5 crowd.
So the under 5s are the ones who most commonly get the multisystem inflammatory syndrome of children with COVID. And there have been hundreds of deaths, thousands of cases and hundreds of deaths of kids in the United States who have had that when they developed COVID. And so the idea is that we don't want any kids to die from that. We know that you can get reinfected, of course, because having had COVID does not protect you from reinfection. So those kids are still at risk. The vast majority of infections in kids under 5 are going to be very mild, but there are rare instances where kids are going to get a life-threatening infection from COVID and require hospitalization, intensive care unit, ventilator, be in the hospital for a long time. So
You'll get it.
yeah.
A couple of quick questions follow up to, you know, a 37-year-old. If that 37-year-old has a mild kidney condition, would you then recommend getting that second booster?
Uh-huh.
Yeah, okay. Thought the FDA required a positive COVID test before a doctor or pharmacy could prescribe.
They do.
COVID.
They
How is
do.
How is it possible then to bring it to Europe in case you get COVID while traveling?
Because you know somebody who will give you a prescription, even though because you're going to Europe, and you just get it. You fill the prescription. Like you know somebody who can write a prescription.
Got it. Okay.
Yeah.
2 more questions. One is, because I do want us to briefly touch on monkeypox, but let's kind of tie up the loose end of COVID. What do you, I mean, this is projection. What do you think the long-term trajectory is of COVID? Should we expect future surges? And what do you imagine those will look like, particularly with boosters that, you know, people will kind of stop getting or what have you?
I think that we're going to have COVID circulating always, that there's going to be enough transmission or enough viral replication in people who are infected or reinfected or vaccinated and infected, that we're going to continue to see. And by the way, most of the world is not boosted. There's a big percentage of the world that's not vaccinated. So there's always going to be viral replication going on. We are going to continue to see viral variants circulating, and the ones that have a competitive advantage are going to cause us to have peaks of infections where transmission in communities will wax and wane. It's going to be viral subvariants or new variants that have an advantage either because they are more transmissible than the current strain that's circulating, or they cause more severe disease. There may be some advantage that they have that is going to contribute to waxing and waning of infections always. And COVID is now sort of bundled into the surveillance that's done about respiratory viral infections. So it used to be pneumonia and influenza, and those are data that are reported every week on the CDC's website and have been for as long as I've been practicing. And now it's COVID, influenza, and pneumonia that's being reported. And so we're just going to see it stratified out, but those kinds of data are going to be just surveyed ongoing. And so if you're interested, there will always be a kind of a look once a week of how things are going. And they also look at it by state. So.
Okay. So Debbie, let's wrap this up with monkeypox. So can you,
do you want me to say something about monkeypox? Or?
I mean, there is a question in the chat, but so let me pose that question because I don't have one formulated beyond a general, share with us everything you know about monkeypox in the next 3 minutes. How can you help prevent catching it if you're not in a high-risk group or engaged in what a high-risk activity? Like, how does a child catch it, which is an event that occurred recently?
Yeah, so, monkeypox is probably circulating in the general population, and it's identified in men who have sex with men because there's a testing bias, and those men are aware that monkeypox is circulating in their sexual networks, and so they will seek testing and they will seek a vaccination and treatment. Meanwhile, the virus probably is circulating in the rest of the population too, although maybe not in as commonly. And so I think that it's just going to be a thing, and close contact, intimate contact, or contact with fomites like dust, sheets, linens, towels, and things, even clothing from somebody who was infected can transmit to an uninfected person. So I think that it's, right now, the numbers of cases are probably grossly underreported, but still the absolute number is probably small. But as we go along and do broader surveillance, we'll have a better idea of actually how much is there and where monkeypox is arising. So where kids, I know there was exposure in a daycare center. There was a woman in Iran who was reported this morning. So it's clearly not just in men who have sex with men. And as we expand testing capability and educate providers to recognize it, I think we're going to be getting a better picture of actually how, what the penetration of monkeypox is and is going to have in the general population.
Okay. I don't have enough brain cells to kind of really fret about monkeypox, but I know it is.
I'm not worried about it, but I'm not going out of the house. No, I'm just kidding. I'm not really worried about it.
Someone did ask a question, and this feels so far off, right? The holidays, but the holidays are not all that far off, things like Thanksgiving and so forth. Mm-hmm. If the situation is as it is, it would just be try and get a booster 3 weeks ahead of time and
keep the windows and doors open, be in a place that's well ventilated, have people test the same day that they, the day of, just sort of do what you can do, and make, smaller groups are probably bigger than bigger groups, just because the risk of having an infected person in there unmasked will be lower because the number of people present will be lower.
And then we're going to wrap this up with a question unrelated to any of this, which is from Bradford. Do you plan to attend the opera this fall?
I do not. But I have been checking Opera in the Ballpark, like the website, because that I would go to. But I did not get opera tickets this year. I didn't get them last year. I actually got them last year, and in July, And then I turned them in because in July it looked like, whoa, this is good. I think we're going. And then I turned them back in, and I didn't even bother this year. But I will go to Opera in the Ballpark. It's supposed to be, I think, Traviata. I don't seem to be able to get my free tickets, but I think I would do that.
Okay, well, I don't think we're going to mention that to Kip Crana, who's going to be talking to members on Tuesday
Oh.
about the
Yeah.
centennial. We'll keep that between us. So we are at the end of this hour. What a brisk and breezy 60 minutes this has been, Debbie. Thank you so much. Just a reminder for those of you who did not take Debbie's Infectious Diseases in the News course the first go round, and I think that was in the winter. There's an encore presentation of it that you can sign up for, and that will include one live stream conversation with Debbie, where you can bring all your questions about COVID, monkeypox, and anything else. Debbie, thank you so much. And
You're welcome.
Just what a wealth of information. And to all of you members out there, thank you so much for joining us. And we will get this recorded and share with you once we get it captioned. So thank you all very much. Debbie, thank you again.
Okay.
Bye-bye.
Bye.